So we have time for a few questions. We've had some questions that have been provided in advance.
Sue's got a question.
But let's go to the audience.
I'm forgetting, Dr. Claudio, how do you say your name?
Tatsui.
Is there any level of the spine that what you're talking that heat ablation would not work?
No, in theory it works on every level. It's tissue and histology independent. I have applied mostly on thoracic spine because the nerves that arise on the spine are just sensory nerves, and I can kill two birds with one shot. I can control the tumor and I can denervate the spine so the pain gets better because it's like I'm severing the nerve that just causes pain. I had a problem in 2 patients that we did on the lumbar spine where you have motor nerves going to the legs, and those patients, I had a patient with a motor neuropathy after this. So I prefer to do on the thoracic spine or on a high cervical spine where I just have sensory nerves.
Thank you.
Mm-hmm.
Maybe just a quick follow-up question for you, Dr. Tatsui. It sounds like this is really cutting-edge pioneering work that you're doing. Are there other centers in the U.S. that are doing similar work, or how would patients find doctors who could do that?
Yeah, not yet. So we are the only ones doing this so far. We developed kind of, it's a process. What I showed here is the result of many, is a learning lessons and applying and modifying the workflow. We are the only ones doing this. There is a lot of interest. I have several friends that are interested in developing this on their practice. We have treated now 97 patients. So I think we have enough data to support the use of that. We learned the lessons how to do this safely. And I think now the next step is to have, to partner with industry to improve the tools to make everything MRI compatible, and then we can expand to centers, to other centers, maybe assisting the surgeons to overcome the learning curve on the first cases and have like centers doing this, focusing these patients with spinal cord compression by cancer. That would be the goal of this.
I have a question there in the back.
Oh, sorry. I'm gonna look it. Oh, this question is for Dr. Tatsui. It was pretty interesting to see the effects of LIT on spinal tumors. My question is, has there been any studies to use the same approach to treat intracranial tumors?
Absolutely. Actually, this the laser ablation was first developed to treat brain tumors. At MD Anderson, I think we are the center doing the highest number of primary brain tumors treated with these glioblastomas, glioblastomas, brain metastases, and sometimes after the patient gets radiation and develops radiation necrosis, that's the other very important application. Outside of the oncology realm, this has been used to treat epilepsy, especially temporal lobe epilepsy, where you have a very specific focus on the temporal lobe, hippocampus. We can put that fiber and destroy selectively the hippocampus. So epilepsy, brain tumors, radiation necrosis, and now spinal tumors.
Excellent. Question there?
If we were interested in doing this with a recurrence, how would we proceed? Do we go through Dr. Rines, or, what would be the next step?
In order to do that, so it depends. It's not for every patient. I think we need to look into every case as an individual case, and sometimes that's a new tool. And we have situations where I think that's more favorable to use that tool. There might be other situations where it's better to use a different strategy. We are, I think, I didn't mention that, but the ideal patient is when you think surgery is going to be excessive, right? So some patients they have comorbidities, or they can't stop chemotherapy. So in a situation where surgery would be not ideal, I think this has a very important role. In a patient that has no other issues, like a primary chordoma that has never been resected, I still think that the best science tells us that we need to proceed with an en bloc resection with clean margins, if possible. There is, I'm sure Dr. Gia mentioned the application of stereotactic radiation to chordoma. that's another tool that is very valuable, actually even less invasive than what I showed. With stereotactic radiation is the least invasive technique available and seems to be very effective as well. So I think a lot of things we're going to learn the lessons as time passes and we see our results. And I think every case has to be individual. We can't really say, oh, it's a cake recipe that we're going to treat everybody. I think every patient has a specific needs.
Would you be part of that overall team where they make those decisions?
I would love to be. Yeah. Yeah. Usually what we do in our institution is a multidisciplinary approach. We always discuss the cases from the surgeon's perspective, from the radiation oncologist perspective, from the oncologist's perspective. And I always tell my patients, what I'm telling you, I'm recommending is not my opinion only, but is the consensus of our department. I think that's how chordomas should be treated.
I have a question regarding, is there any way to make our immune system to attack brucei of the chordoma tumor? Any research done about that? And is there any way to have some drugs that will prevent those switches to turning off these genes that create the chordoma tumor in the first place?
The first question was, is there a way to have the immune system target cells that express brachyury? Yes. Anyone want to take that?
Well, I think we've shown that the immune microenvironment does, at least from our preliminary work, does play a role in terms of, patients that have more lymphocytic infiltrate. They tend to do better than the ones that had less. So there does seem to be, I think there is a role that immune microenvironment could play in terms of chordomas, in terms of whether or not they can train the immune cells to attack specifically brachyury. That I think that would be a great idea, but I don't know if that.
Josh, maybe you want to mention the trial that Chris Heary's doing with the vaccine?
Yeah, so there's actually two different vaccines that have been developed. One is a yeast-based vaccine, and one uses a different technology called TRICOM. But in both cases, the idea is that you stimulate the immune system to recognize and seek out and destroy cells that express brachyury. And those clinical trials are ongoing at the National Cancer Institute right now. If you go to the Chordoma Foundation's website, to our clinical trials page, you can find out information about both of those trials. But I think there's a lot of agreement that that is a very promising approach for the reasons that Dr. Lin mentioned. Brachyury is so restricted to the chordoma. It's not expressed in normal tissue, so that if you were to stimulate an immune response to cells that express brachyury, you're not going to have off-target effects. It's not going to damage other organs. So I think it's an area that is certainly seems very promising, and there's some preliminary research going on in that area. One more question.
All right.
Thank you. My question is for Dr. Lin, and with your research with the brachyury, are you looking for this to be more of a primary treatment, or would this be more of something as a preventative for recurrence?
I think if we can, so let me take that back a little bit. If we can find small molecules that can actually inhibit or degrade brachyury, the goal would be to get them into clinical trials, which would typically not be as sort of the primary occurrence as sort of the first way you test it. I think ultimately, though, if we can actually do this, any sort of small molecules that emerge from these efforts would probably be used in combination with sort of the standard of care that we already have today, surgery, radiation, especially considering some of the more promising results we're starting to see that radiation can sensitize a lot of tumors to small molecule-based therapies.
Excellent. Well, please join me in thanking the speakers. It was really a stimulating panel.